Thank you, Iridex, for inviting me here. It's really great to be with Nathan Radcliffe from New York. I'm from Toronto. I think Nathan is really what I look at as sort of the emerging, not even emerging, he's already here, superstar in glaucoma, young guy with a lot of great ideas. I used to be there one day, so I look at him with envy as far as his great potential, and really a great way to conceptualize important concepts in glaucoma: surgical, diagnostic, lasers. So I'm really privileged to be with him here today. And I mean, we're both really excited about how we're kind of revisiting using glaucoma lasers in our management of patients. I mean, we've seen so much improvement in diagnostics, in surgical treatments and medications. And lasers, we had some boom times, and it's been a little bit of quiet. So I'm really pleased that we've got some new things to work with, and I think we might share some ideas that maybe not as conventional. So we're going to have Nathan actually start off, and we're going to have very much a conversation, maybe a few arm wrestles if we need to, make it a bit interactive, and we hope we get some question and answers from, or questions from you guys. So I'll hand it over to Nathan.
Thank you, Ike, for that wonderful introduction, and Joan and Iridex, thank you for having us. And it's an honor to be here talking about lasers. Ike, I remember you speaking about minimally invasive glaucoma surgery a few years back, and you mentioned the gap between our safe eye drop therapies and these more invasive but yet also more efficacious surgical therapies. And this is all about filling in the gaps. And it's been exciting to think about ways to do it. And it's a pleasure to be here with you today, kind of talking about some new options that we have. And we'll cover two different options that sort of cover that gap from two different sides. But I'll start with the patient. And Ike and I wanted to keep this conversational. And so here we have a patient. It's a 58-year-old myopic man, with ocular hypertension, using latanoprost, and it admits that he forgets sometimes. And he's a great glaucoma patient because you can immediately see the difference between his disease severity and his functional impairment, which is he's got a good bit of optic neuropathy, as you can see with all the red on the cirrus. It's not myopia, I assure you, and I'll show you how I know that, but a full field. So you've got to make sure that your therapy doesn't turn him from an asymptomatic patient into a symptomatic patient. Here's how I know he's got something going on, is because while he's taking his latanoprost, his nerve went from looking like this to looking like this. And this is some of the fun technology I've played around with, where we've aligned two photographs that were taken several years apart, flipping back and forth, and you see that his optic neuropathy has progressed. So how are you going to approach this type of patient? As I said, he's taking latanoprost, his pressure's borderline, and he's forgetful with his drops, full field, but some real disease.
Well, I mean, Nathan does some cool work with this flicker disc photography, which I think is neat to show the progression. And this is a problem. We give patients drops and we don't know what happens when we don't see them in the office. And here we happen to actually get a history that this chap is not following his medications, which is a real problem for whatever reason. I envision the day one day where we don't use drops. I mean, maybe it's a bit of a dream, but that's kind of my dream, because I think drops, except for the odd patient, are very difficult. And I won't go through that detail, but here clearly something needs to be done. And I will often actually at least discuss laser trabeculoplasty when I'm starting a patient on medications, just to have it in there. I don't always rush to primary therapy, although if I'm really concerned or a patient is really keen on a non-medicine alternative, I will offer primary. I don't know about you, Nathan, but yep. I will offer primary therapy. But in this case, this is a perfect example. The reason it's up here, of course, is for that reason that, going through the whole rigmarole again, circle of medication use is probably not going to, achieve the result we want. We have progression. It's really an ideal situation to consider doing laser trabeculoplasty, getting him down to a better target. I think for him, he would need a target that would be down into the teens.
And I agree completely with all those things. Setting the stage for the trabeculoplasty, maybe years before you're going to need it, is I think also the key. Patients sometimes can have reluctance or apprehension, but if you connect it to their narrative, reminding him that this isn't something we're doing because it's a last-ditch effort, but rather this is something I'm doing to address a problem you're having, which is forgetfulness. And we all are making choices. You might want to choose a trabeculoplasty. One of the things Ike and I are going to try not to do is tell you things that you already know. And so we have slides up here. They've got all the information on things like trabeculoplasty. I think we know the model, and we're going to talk a little bit about a different kind of trabeculoplasty, which is MicroPulse laser trabeculoplasty. And I guess I'll go into a little bit about what MicroPulse technology is and how it works. So if you think back to argon laser trabeculoplasty, you have a thermal laser that's delivered in a continuous fashion. And if you've performed argon laser trabeculoplasty, you see a direct thermal effect with contraction of tissue as you're applying the laser. The concept of MicroPulse, I'm going to skip ahead here, is to break that continuous laser up into little envelopes, 1 microsecond envelopes, where the laser delivers the energy and then actually allows a cooling period and then picks back up. The analogy I've used is waving your hand over a candle as opposed to just holding your hand over a flame. It's that thermal spread that creates the heat and the damage. You can deliver the same amount of time over that flame if you just break it up and allow some cooling.
And someone has a lighter, I can actually show, Nate will show how this works.
Yeah, we were doing some of that at the bar last night, but maybe not now. So this concept of the duty cycle refers to what percentage of the cycle is the laser delivering energy versus resting. And you can set that duty cycle, but a 31% duty cycle would be a half a millisecond on and 1.1 milliseconds off.
And I think the other way to look at it too, I mean, I think the candle analogy is great. Obviously an Elton John fan, right? Candle in the wind, but even phaco, right? I mean, phaco, we're all, hyperpulsing our power delivery. And we changing our duty cycle depending on density of the lens, and we know the savings we have with thermal energy and efficiency as far as at the phaco tip. So I think this is a long time coming actually. I'm actually surprised it hasn't been something that we haven't been doing, longer than we are, where we're actually taking advantage of the benefit of laser without that thermal damage, the collateral damage to the tissue. Understanding thermal relaxation time of cell structure and reaction to energy, and saving the benefit of the laser, but not the collateral damage that we see with that thermal energy. And I know, Nate, I mean, we've seen retina guys take advantage of this.
Yep.
And I think it's great to see this now into the glaucoma space, so.
Yep. So I think what I'll actually do here is just sort of show you what this looks like. And we have two examples. One is more of a schematic showing you the spot size. And with MicroPulse, we typically use a 300 micron spot size. SLT is more like 400. This has some advantages for me. One that comes to mind immediately, and there's actually good evidence for this, is laser trabeculoplasty in patients who've already had a laser iridotomy. And they've had angle opening, but they're still a little narrow. And you want to get into the angle, get the trabecular meshwork, but now there's a little bit of a higher risk of hitting other tissue. You could hit on the one side the iris and on the other side the endothelium, and with SLT with a larger beam size, it's a little more tricky. I've found that the MicroPulse laser gets in there very nicely into those narrow areas.
Yeah, how many have seen PAS after SLT? And well, ALT, we know we've seen that, but what about after SLT? Because I examine some of my patients later on after SLT, and again, SLT has had a role, of course. Yeah. We're trying to differentiate a little bit here, but PAS formation, and certainly any laser trabeculoplasty has a risk for PAS, but I think that spot size probably helps us get in there a little bit tighter. I think it's a bit of an advantage here, yeah. And the gentleness with the energy.
And so why don't I just show you, I think we have a video of Ike's performing MicroPulse laser trabeculoplasty here.
Yeah, we did have a video here. Hopefully it'll play. Is it playing? Oh, okay. There you see it.
Great.
So you're basically seeing the red aiming beam on the video there, and you're seeing that placed on the trabecular meshwork. You can see a lot of space in the angle there. It's focused very well, and basically going along here. And we typically, I know Nate will probably talk a bit about this, but we basically take essentially overlapping or spots touching each other, so they're side by side. You basically get about 100 spots for 360 degrees. It's a very straightforward approach that we're familiar with a standard trabeculoplasty.
Yeah, to say the learning curve, if you're already performing trabeculoplasty, is essentially non-existent. You just make sure you're straight on your settings, and I'll go over those in a minute. Suffice it to say that using this technique, they've evaluated the trabecular meshwork with electron microscopy and found no discernible difference or no evidence of any damage, which is precisely what you would expect. And while you're applying the laser, you see no tissue effect. And we know with argon laser you'll see contraction. With SLT you can see champagne bubbles. Here laser's applied, and you don't see any effect. So just a little bit on the settings, and then I'll compare SLT and MLT a little bit. Different powers have been tried, and I'll show you there's a dose response curve, which is always a good sign that you've found a therapy that is efficacious. Currently, most of us are using about 1,000 milliwatts. I've done a lot with 700 or 800 as well. Spot size 300 microns. You're using an exposure duration of 300 milliseconds. And again, that is many pulses of laser with interruption. We use a duty cycle of 15%. So that's a pretty small proportion of the overall exposure that the laser's firing, and we'll typically treat 360 degrees.
So those of you that are into math, and I mean, I remember when I programmed my phaco machine, I would really diligently figure out how many seconds I'm on and off. So that's basically 300 milliseconds on, 15% duty cycle. That means if you do the math, of course, that's basically a 2-second pulse duration as far as the actual pulse. Within that pulse, you have 300 milliseconds on and 1.7 seconds or 1,700 milliseconds off. Every time you get a pulse of energy. So you have more off time than on time, 50% on time only. So it's a very short little on time in that individual packet of delivery.
So this is just a comparison, and I think I can certainly speak for myself. I do both. I do MLT and I do SLT, and so when might you use one versus the other? That's sort of one part of the story if you have both of them sitting in your office. There are other questions though as well, which make this laser unique, which is, well, if I'm starting a new office and we need an argon laser, we want to do some retinal laser, we want to do some iridotomies, can we also provide ourselves the option of MicroPulse without adding the additional expense of a SLT unit? So some of this is related to practice efficiency, and some is related to if you had both and you're in all the ideal settings, when would you choose one versus the other? And the other thing I'll explain is that in my office anyway, I have this in one of my lanes where I'm seeing patients. So it's my regular slit lamp. I have the 532 laser there, and I have a little piece that fits on the slit lamp. And so while I'm discussing the laser, I tap it and say, this is the laser that you're going to have. And the patient, I think, is a little anxious about what it might mean, and they see the box sitting there. I don't have to move the patient, so from a time standpoint, there's a little bit of an advantage there. It's actually quite practical. Okay, looking at MLT versus SLT, 532 nanometers. Have you done any 577 MLT?
Not at this point,
yeah.
no. But okay. I think that's an exciting area of new development here.
We also have, so again, not seeing any thermal effect when you're doing MLT. As I said, you can see champagne bubbles. They're both repeatable, and I'll show you some evidence where MLT has been performed after other types of laser trabeculoplasty. Again, you're not seeing anything post-operatively. Probably for me, the single most important distinguishing feature is that an eye after MLT is, and I don't say this a lot, but really, in my experience, 100% quiet. And I mean, you've got to look at the chart to see which eye had the laser. And this is in your half-hour check, which frankly I think probably isn't necessary after MLT, because I've never seen a pressure spike. And that changes the dynamic for me. SLT we know has proven efficacy, works very well, but we also know you can have pressure spikes. And for some of these patients on the edge, you're hesitant to press their pressure even higher, even if you know that 6 weeks down the road you'll get a good benefit. But it also has some advantages for the patient management. I never use steroids or NSAIDs after the MLT, and I also feel more comfortable beginning the cessation of their glaucoma therapy the day that the MLT is performed, whereas with SLT there are a few extra visits as we first make sure there wasn't a spike, then look at their pressure treated, and then look at withdrawing therapy, which can be a little bit more complex.
Yeah, I would echo exactly what Nate said, and we've had some early experiences now, and we've actually had a number of patients where we've done SLT in one eye and MLT in the other eye for patients we treat bilaterally. I don't have too much of a problem treating bilaterally if the patient has a relatively good nerve and not a high risk. Pigmented eyes, I'd be a little bit careful, but otherwise routine eyes, and we actually can see the difference with that. I mean, there's no question, and I certainly had some skepticism because we certainly were very pleased with SLT, and this isn't necessarily at all an SLT bashing session at all. We have 2 or 3 SLT units within our practices actually, and we do use them. But I'm very intrigued at what were the possibilities of with MLT, what we're seeing. And I would echo what Nate has said as far as the treatment there.
Yeah.
Question for you, Nate, what about with pigmented eyes? I mean, with SLT, we got to really be careful with IOP spikes. What has been your experience with like a pigment dispersion eye or someone with a 3+ pigmented angle? Do you change any settings?
No, I've done maybe under 100 MLTs, but enough to see a wide range, a typical range of pigment. And again, I just haven't run into any problems yet. So I think it's a great option, and I've certainly now I have my algorithm that parses out a little bit. But in eyes where I'm looking to avoid any type of spike, this is where I go.
Yeah, I mean, that's one distinguishing point, because with SLT, if you don't adjust your power with like a 3+ pigmented angle, you're at very high risk for an IOP spike. And obviously I was concerned with MLT as well. And we've had now experiences with some pigmented eyes, and I've actually been surprised that expecting something to see there but not. And I think I would still caution. I don't want to give the impression that, don't worry about it, but I think that it seems to be at least less of a concern, which I think is a testament to how little we're doing as far as trauma.
Okay, so let's look at a little bit of data that we have here. So I think I went through the parameters here, but again, this is what your laser console actually looks like on the 532 unit. So again, Cornell just opened up a second office, which is a little bit of a satellite office, has retina, has some cornea, and has some glaucoma. And right now that office has the 532 there as the argon laser. So you can do MicroPulse, you can do retinal laser, and you can also do iridotomy. And here's some data. Now all this data comes from Dr. Gossage. I've been a little bit lazy myself, and I haven't put together my series yet, but that's on my to-do list after I get through this busy academy meeting. Right. So we're getting our data together, but you can see here 3 different power settings, and I think this is part of our learning curve, is figuring out what the ideal power setting is. Many of us, I know Steve Vold is using 1,000 milliwatts. I've been using 1,000 milliwatts, and I think you have as well. So we're feeling encouraged because we've yet to run into any problems, and I'm not sure whether we'll go higher or not. But you can see with 1,000 milliwatts, a couple of things. One is more efficacy than with either 700 or 300, up to 30% pressure reduction. And again, an effect that grows a little bit over time. You get 21, 22% after a month, and then it comes up to 30%. In these eyes, it's a blend of eyes that you'll see here, but many eyes with prior ALT, and even prior SLT, and even prior MLT. So you're seeing efficacy. That it's not declining over time speaks against regression to the mean, which is always a concern in these sort of single-armed trials that you see. But I think this is some encouraging evidence.
Yeah, I think it is encouraging. That's why we started at 1,000, and I think it's. I think we're seeing we've got about 6 months now. We're seeing, I think, some similar trends here.
So again, we promise to try to keep it clinically relevant. So here's one of my patients. Pressure is about 20 millimeters of mercury on 3 drops. Again, a little bit more visual field damage in this patient. Maybe in a little bit more trouble, I think. Do you have an algorithm on always laser before an incisional surgery, or any thoughts on that?
I don't always laser, because I think it depends how far away I'm from the target. If I think I'm going to be way off from the target, then I won't. And also I look at the risk profile of the patient. What's the surgical risk? I have to say, I mean, looking at that you can see that fixation defect right at the fixation point there, which concerns me right over here in this eye.
Yeah, absolutely.
You can see in the left eye. And that really worries me a lot, whether it's incisional surgery or whether it's an IOP spike that could snuff out this patient's nerve and take him from a 20/20 to a count fingers eye. Yep. And particularly high, I would, if I did filtering surgery on this one, I'm not sure I would, certainly not right away, I'd be worried about that. And I see it enough in my practice that I worry about it. So I want to choose something that would be least risky in terms of that aspect of it. It's interesting, because I mean, I think I would look at this as certainly something I would try laser trabeculoplasty with. But I'll be watching this person like a hawk normally in the first few hours after the laser for a pressure spike. And I'd be having my pseudozolamide in my hand if need be, to be able to use it. I don't actually have it with me now. So, you're reaching your hand out. So that's what I'd be worried about. It's interesting, we're going to talk about transscleral CPC later.
Yeah.
But it'd be the same eye if MLT wasn't enough or laser trabeculoplasty wasn't enough. I'd be discussing maybe not doing incisional surgery even.
Yeah.
Which sounds a bit odd because you're saying, wow, you're going to actually go to transscleral CPC before Trab. And we'll talk about, that's a little tidbit for later, but that's my thought. I don't know if you agree with it or not with that, Nate. But
yeah, no, I agree. I mean, this is an eye, the left eye in particular is in trouble, or maybe it's time to lock the right eye down a little bit. With these patients, I think there's some risk of them going so Tim just showed us a lens here that I'll talk about in just a minute. Thanks for bringing it up, Tim. So this is someone who I think is probably going to need some more grand intervention. But for me, part of, the psychology of managing a glaucoma patient is important. And I think part of the due diligence is to show them that you're trying other things, but to try them and have them be safe for the patient and hopefully efficacious as well. So we have.
I mean, in that last patient, if we really find less ILP spikes, which we need to prove that if we do, that would be a distinguishing characteristic in terms of what platform to use for LTP, for trabeculoplasty, right? So I think if the trends show this to be as gentle as it is with ILP spikes that be lower, that could be one advantage. I think that's a consideration here.
Yeah. I've used it a lot for eye drop replacement. And had great results. And that to me is kind of interesting because we know if there's one predictor of efficacy of a laser, it's actually having a high baseline pressure. Those are the people who typically do well.
John, you can move that computer out of the way on the side, yeah. On the bag, thanks.
But that's sort of where I started, and then as my comfort with the laser's grown, I go from replacing drops with the laser to adjunctive therapy to trying to get people out of other more aggressive interventions. In fairness, I think there's still some questions. MLT long-term efficacy, we're still sort of waiting to get that data. We do see a good effect 4 months after the laser, and I do believe it's repeatable. And as you know, even from the SLT literature, it can take a long time, and the design of some of these studies is actually pretty tricky because showing that something's repeatable versus distinguishing out disease progression can be challenging. And
that's an important point because I mean, in general, laser trabeculoplasty has an issue with attrition over time, and that does make it a little bit of a less robust procedure. Mind you, the risk profile is so good that you probably don't have a lot of harm to do. But that's on our wish list. Now, repeatability is a big question. We talked a lot about it. We've heard a lot about an SLT. We don't know about an MLT yet. With the minimal trauma, maybe we may have a better theoretical advantage for repeatability, and that would be nice. But I definitely agree with Nate. I don't want to make it like this is the best instance sliced bread and we're done and shoot and fire and you're done. Patients need follow-up. When they do escape after 20 months or after 2 or 3 years, they can sometimes bounce up pretty high. So they do need to have follow-up, and that's important for our patients. Yep. Some patients think it's a one-time deal, they're done. Yep. And so that's always important. So I think it's encouraging the early returns. That's what I think our message is here. And if there's anything, if it sort of predicts the future benefit, then I think you're seeing some of this theoretical advantage. And we definitely need some more data and studies, and that's why we look forward to collaboration with each other and others to sort of get that information.
Agreed. So what Tim handed me here was a indexing MicroPulse lens. Again, when you're not seeing a thermal effect, you may want a way of sort of tracking where you have delivered your pulses, and this actually just has 5 little bars there. Wow. Can you get through a trabeculoplasty with that one?
It's for folks in New York, but it's...
I have one, I've used it, it's nice.
Yeah. Try it.
Yeah.
For those of you that are wondering on the camera here, we actually had to move some computer equipment because we had a packed audience here. So just in case you're wondering why I was directing traffic over here. So it's great.
So I also have to thank Dr. Gossage and his associates who've helped us with some of the data that I've shown you today. And now we'll switch gears a little bit, moving up the spectrum a little bit, but maybe not as far as we all used to think. I know Ike and I both have reviewed the data, some of which has been produced by you recently with some of your work with tubes and tube shunts and even trabeculectomy. And we've also reviewed the data on transscleral cyclophotocoagulation. And we want to have a discussion about the safety of this laser, because some of the therapies we've been doing, trabeculectomy, tube shunt, have a more serious risk profile than we may have appreciated. And transscleral has a great efficacy profile and a risk profile that's probably a little more favorable than we've recognized.
Agreed.
My question for you is, and I hope that this plays, oh yeah, it's playing, great. So here's a patient who just escaped control. Is it cycling through, or is it just doing it once? You can see this glaucomatous progression. Yeah, basically a patient started with a little bit of cupping, progressed, had a disc hemorrhage, and then eventually developed end-stage cupping and hemiretinal vein occlusion. 20/20 vision right up until the vein occlusion. And the question is, at which point should have an intervention have been done, and which intervention? I'll give you a patient that I just saw last week. This was a 93-year-old woman, pressure's 29 on 4 drops. She is pseudophakic, has never had a trabeculectomy. She has had trabeculoplasty, otherwise a virgin eye. And I'm talking to her about an intervention that she needs, and I don't think anyone's going to debate that someone with central disease like this, double arcuates in each eye, fixation-threatened glaucoma is going to need an intervention. And as I'm talking to her, she's asking me questions like, well, I have to get the medical clearance, it's tough for me to get transportation. She's 93 and a good 93, but slightly frail. Doesn't have any family to come with her to the operating room. And I know that I've got a therapy that can bring her pressure down, maybe 50%, that I can do in the office. And this, for me, having this option has really been something wonderful for both me and for my patients. So I can do this laser in the office. I'll do a retrobulbar block in the office and watch the patient afterward, but I've had great success with that. And just take care of the glaucoma that day. No need for the medical clearance, no need for the trip to the operating room, no need for them to have a family member who has to wait in the operating room with them for the whole day, which is a big problem for me. So just looking at a little bit of the data that we have in trabeculectomy versus transscleral cyclophotocoagulation, they both have fantastic efficacy. And many studies have shown this for both laser and trabeculectomy. There's a risk of visual worsening in any of these types of glaucoma, and sometimes it's related to a complication, and sometimes it's related to the progression of the disease for those 50% who don't have the pressure reduction. Choroidal hemorrhage is the one that, for the 93-year-old, is something I just can't get out of my mind. And I guess I've been burned a few times with that one. Yeah. There's, in some of the literature with transscleral cyclophotocoagulation, there's a risk of ptysis. Those are usually high-risk eyes that are being operated on, and often neovascular glaucomas. So there's some contamination, I would say, of the literature there. And again, these other points that I've been making. Again, I promised that we wouldn't tell you things that you already know. So transscleral cyclophotocoagulation, 810 nanometer diode laser. This is the Iridex, many Iridex systems, but either the Oculite or the IQ. There's the fiber optic handpiece I think we'll have a picture of for you. And we know that this is working as a complementary mechanism to most of our other therapies. Repeatable, titratable. No procedure that can't be performed after a transscleral cyclophotocoagulation, and no procedure that you could perform that would make it impossible to do this. You agree?
For the most part, yeah.
Yeah. All right, and so again, it can be done either local with the retrobulbar block, and the indications are for these aggressive glaucomas, and we're sort of questioning what are the new indications?
Yeah,
I'll put it to you.
And I think this is the traditional sort of approach when we look at cyclophotocoagulation, and that's part of the problem. If you look at the literature, most of the results that have been published have been in very high-risk eyes, and it's understandable why this was initially used in that group because of, perhaps, ensuring that we're avoiding potentially theoretical complications. So that's why, of course, any of these patients here that we operate on or do anything for, we're going to have a higher risk of vision loss, higher risk of complications, and even a higher risk of ptysis no matter what we do. So we have to remember that's the group that we need something to be done in an effective manner, but also has a higher risk. But it also means when you interpret the data, some of the stigma attached to photocoagulation or ciliary body treatments are based on some of that old, really, really sick eyes. And as you see here, these are kind of the traditional approaches, and I do believe that in these eyes there is a reason to do cyclophotocoagulation. I'm absolutely not saying that they're not. These are very, very complex eyes that require something more, and often you can't really do any conjunctival surgery. But I mean, what I think is, what I'm certainly seeing, and I have to tell you, I did my fellowship back in 2001, way back when now, I guess. And I came out as a gung-ho surgeon. I'm basically going to treat everything surgically, right? You may be, and everything gets a tube or a trab or non-penetrating surgery or everything else. And you realize after enough follow-up, which you may be getting soon, that these procedures have a significant complication risk profile. And I literally revisited cyclophotocoagulation. My volume, I think when I first started, my first 3 years was maybe one a month or so for that really NLP painful eye. And now my volume, I don't know if my fellows aren't here, I'll have to wonder where they went today, or maybe they slept in. But they'll probably tell you we do somewhere between 10 to 12 or more in a month. And a lot of these are not the traditional approaches, they're what I call the new transscleral. So for example, after a failed trab or a failed tube, I'm not one to kind of just run through the cycle again and just repeat what I did that failed. So I will often be looking at this procedure. It's often a primary surgical, not often, but for certain patients it's a preferred primary surgical procedure for the patients we mentioned earlier, patients who I'm really worried about going in and operating. Now you may think, well, that must be a patient who's going to scar easily, who's going to fail in a trab, an African patient with failed trab, and that's true. But what I'm really worried about mostly, and we'll talk about this a little bit, is eyes that are really at risk for snuff out during filtering surgery. So in eyes with good vision, we're using it more and more. And we've changed our technique a little bit. We've modified our technique, which we'll talk about a little bit. And what's interesting in glaucoma is now combining different options. Maybe doing MLT a little bit to get down and get some traditional outflow approach optimized, and then doing an inflow procedure to combine in synergy to lower the pressure. Or doing, we have patients who we've operated on who we do pressures 28, 29, have a cataract, they're a bit older. We'll do what we'll call a gentle cyclophotocoagulation. We'll talk about that later. The pressure comes down to about 20, right? I now go in and do a phaco plus a mixed procedure, like maybe an eye stent, or in Canada we can put a couple stents in, and I've got them now down to like 13 or 14, maybe on one med, when they started off at 29 on 3-4 meds. And I've used Transscleral to get me down a little bit, and then I've added the phaco plus mix to get down in combination to get down what a phaco trab would get, but would have a higher risk. Yeah. So I think it's very cool being able to now mix and match technologies to do that, whether it's laser plus laser, inflow versus an outflow, or whether it's a surgical micro device with these procedures. So I think that's pretty interesting. I don't know if you have any experience with that yet, Nate, or what your thoughts are on that.
Yeah, I think absolutely. It can be combined with cataract, performed prior to, and again, it's versatile, but also titratable. I've encountered one patient, this was something I hadn't thought about, I admit. It was a patient with ocular albinism and no pigment in their ciliary body. And I'll tell you, that's someone for whom this treatment probably isn't going to get you where you need, because you need that pigment in the ciliary body. And the more pigment of the eye, the lower you can go on the energy settings. But again, some of these eyes with the better vision, you just play it a little safer, and knowing that it's completely repeatable and titratable, lots of options.
Yeah. Agreed.
So again, we know the mechanism, which is affecting the ciliary body, decreasing aqueous production. This is the G probe, and where are we headed here?
Yeah, so I mean, and I see one of my former fellows up here, and Patrick certainly had a lot of experience with cyclophotocoagulation in eyes, sighted and otherwise. So, good answer. So, obviously a discussion about risks are important with patients that we're doing any procedure, but including cyclophotocoagulation. Even with laser trabeculoplasty, I make sure I obtain a full consent and make sure the patient understands what the issues are. These eyes, of course, I mean, we have to always be concerned about risk of progression. Pain is something that can occur. We usually block patients. Now, in the office, we'll typically do a peribulbar block, two site injections, just because of the concern maybe the retrobulbar going back and brainstem and whatever else. But In the hospital setting, we're doing retrobulbar injections, and I think that certainly gives a lot of comfort for those patients, you know. And a typical regimen is basically continuing with the glaucoma drops post-operatively until their next follow-up. We do give them topical steroids and a topical cycloplegic to control inflammation. And I think topical NSAIDs is something that's of interest because in our well-sighted eyes, you know, we do have some concern about CME risk.
Yeah.
And I use NSAIDs even with my filters because there's a CME risk as well. And so I think that there's an evolving potential benefit in that area as well. So, and Nate's already mentioned again the benefits about, you know, all the restrictions we put on our patients, we can basically kind of put them aside and you know that we can sort of have a bit more confidence with the patient going home.
Yep. I think it's a great point about CME, a risk for any filtration surgery. I just had a case of bilateral tube shunts. I was actually imaging the macula as part of a glaucoma progression analysis, and I was just shocked to see CME had crept up. So something you have to keep in mind regardless of the surgery.
Yeah. Agree. So, I mean, we thought we'd share a little bit of data. Again, as Nate said, we don't want to bombard you with too much data, but there has been studies looking actually at this procedure in eyes with good vision, reasonably good vision. And I think it's a little bit reassuring as we compare these results with what we see, for example, with our tube results, TVT, AVB, ABC studies out there that have been published, and of course the AGES study. And when we actually look at the difference between, you know, vision loss between these studies, actually, if you look at this, for example, transscleral cyclophotocoagulation actually comes out even relatively favorably compared to a similar like population. Of course, this isn't a randomized controlled trial comparing the two between Trab eyes, for example. So I think that there is some examples of this, and as we see, you know, a variety of different studies that have been published, and some of these numbers you may say, wow, you know, 30% vision loss, 2-line reduction, that seems really unacceptably high. And therefore, I don't think it's a procedure that I would offer. And I would probably say the same thing. But then when you look and compare it to other things we would have done anyways, a Trab or tube, then you look and see that a high percentage of patients, almost half, in the TVT trial, a relatively well-designed trial, lost, in this case, 2 or more lines of vision. Yeah. So it's unfortunate that no matter what we do for some of these really, really advanced eyes, that we do lose vision, whether it's from the disease itself, which I think often it is, or from the procedure. That's a risk. And I tell my patients that it's a balance. It's hard, of course, to manage some of these very, very sick eyes. Remember, these are some pretty advanced eyes that we're talking about in these studies. Yeah. I think if you take a group that maybe has less severity, we may find a different type of vision loss. Yeah. Any thoughts on that, Nate?
Yeah, well, I'll just say that, you know, I think we're all surprised a little bit by some of the data from the tube versus Trab study that showed high likelihood of visual loss. But this is how I consent my patients. And I don't want to play the game where I say, I think I've got better outcomes than this trial. I say this was a trial done by fantastic surgeons at all the reputable institutions, and here's the data. And if we don't want to go ahead with your trabeculectomy or your tube based on this data, then we have to find something else. And that to me, I think has just led to a more informed conversation with the patient, better expectations from patients in terms of what they can expect, but has also led me down the path of cyclophotocoagulation in different circumstances.
Agreed. And I kind of mentioned this already, like this is the kind of visual field, you know, when you operate on these patients, I really in my heart believe the risk of snuff out event at the time of a Trab or tube is extremely high. Like I think it's higher than 6-8%. I mean, that's what some of the studies have shown. And I would quote my patients, a risk of like, 15-20% risk of snuffing out. Not vision loss by 2 lines. I'm talking about going from 20/40 to count fingers. Yeah. And so I really believe that a titrated, and I like that's an appropriate word to use, a titrated transscleral cyclophotocoagulation I believe is safer. I tell them on average I may need to treat you twice, but I'm doing it in a titrated, graduated fashion. I'm not opening the eye up and decompressing the eye and having fluctuation of their IOP. And we will watch these patients closely, but sometimes we need to add or take away medications, but I believe the risk is a lot lower. And the hypotony risk, which we're all people become sometimes a little terrified, in an eye that has otherwise a normal functioning ciliary body, I don't think you have a lot of concern. In a neovascular eye, it's a little different. No matter what we do in those eyes, we get tube exposures, we get hypotony with those cases. And if you do CPC, you're going to have a couple cases that may occur in those very, very neovascular type of eyes. But in well-sighted, normally functioning eyes, I've been fortunate that we've been fortunate in terms of managing it, but that's, I think, a very, very low risk comparatively speaking.
Yep.
So procedure-wise, I mean, again, this is a technique that is very similar to what's a traditional approach for transscleral photocoagulation. Anesthesia of choice, we mentioned. I haven't been brave enough to do it under subconj, but we'll talk about that later on. There might be some neuromodulations of laser trabeculoplasty, of cyclophotocoagulation, pars plana that may be a benefit, micropulsing it. And basically, essentially applying the laser, ensuring that we're hitting the ciliary body. So retroillumination is helpful in some eyes because in a large myopic eye, the ciliary body may be farther back from the visual limbus. So take a little pen light, shine it to the pupil, look for that scleral scatter, look for that scleral spur, that white ring around the limbus, and then right behind it is the darker where the ciliary body is, and that's what your target's going to be. In most eyes, it'll be a millimeter back, and that's what the probe is designed to be like. I think I'm sure there's a picture of a probe there. You see the position of it, and if you position the curved end along the limbus, that'll get you back, a millimeter back to hit the ciliary body. Remember, though, in some of the myopic eyes, it may be farther back. I don't know if you do anything, if you have any other comments on that part of it.
No,
You agree?
Yep, same approach, same technique, and retroillumination is really helpful.
And typically doing a 360-degree treatment, some people do avoid the 3 and 9. Some people avoid superior in case they want to do a procedure up there. I don't know how much of a concern that is. And anywhere from 14 to 16 spots typically may be used, and that's kind of a standard approach.
Yeah, I've had many cases where I'm navigating around some hardware that's in the eye, and in those cases, typically I have a supratemporal bleb or a supranasal tube. I'll just get everything I can where I don't have a patch graft or anything like that underneath it. Yeah.
So I've been really intrigued with the slow coagulation approach that Doug Gasterland, who's been, of course, kind of the grandfather of the G probe, and a lot of work with Transscleral Cyclophotocoagulation. I'm getting all this flashes in my eyes as paparazzi taking pictures here. No, I'm kidding. No, take more pictures. Seriously. Come on, smile for the camera. One picture now. Come on, we're waiting for you. Okay, time's up. All right.
Okay.
Perfect. Sorry to give you a hard time. So, I think this is something that I think has a lot of potential promise. And I don't know, Nate, I mean, what is your approach? Maybe I'll let you take that one.
Well, I'll take, what are we doing when we do endocyclophotocoagulation? We want to treat uniformly. We want to deliver a treatment to as much of the ciliary process as possible. And we don't want to necessarily explode or pop the ciliary processes. And when you're doing transscleral, there's a way to achieve that type of a delivery. You're providing a more sustained amount of energy, but without sort of that explosive pop, and that's a slow coagulation. You're delivering the energy at a lower level for a longer period of time, and in that case, you're probably going to get some thermal spread, but without having sort of an explosion of the ciliary process.
Yeah, I agree. So I mean, our standard has been that, 175 or 2 watts of power here with 2 second duration, and that's been kind of our standard. But the difference here, you see, we have a lower wattage over a longer period of time. And if anyone has seen, I should have put a video on endocyclophotocoagulation. You can see if you put too much energy in, you see a pop of that process, and you actually get some bleeding sometime. That's what we want to avoid. And doing this is helpful. In fact, one of the challenges with transscleral CPC is you can't see the reaction of what's going on. And some will say, you want to hear some pops, and then you back off a little bit.
Right.
So this is a good initial approach, especially for well-sighted eyes. I think it's a good initial first start. And I'll typically do this once at least, and maybe even again if I get a partial response, and only if I have not achieved as much as I have to, then you have to go in, or you have to go to a higher setting. And then I will go to the standard 2-2 setting.
I couldn't agree more. I typically start with this, but if I'm doing a repeat therapy, I will increase the energy and decrease the duration. And if I have an eye that just has a very, very high pressure and is not as well sighted, I may start with the higher power. But again, it's the titration, and it's sort of tailoring the therapy to fit the needs and the risk profile of the patient. And it's great that you have those options.
Agreed.
One thing I've wanted to do but haven't yet is just deliver just a few pulses, every few months, and just keep ramping it along. Maybe we'll get there with MicroPulse. So again, just showing these are some of my patients, of course, but this is someone with florid rubeosis who had a tube shunt that failed. Here's a tube that was well placed, but actually it looks like vitreous, but it's fibrin clogging it. Here's a tube shunt with some blood, and these are really just here for gore and fun. But again, just reminding us that, there are problems with any therapy that we do. This is a tube filled with silicone oil. Any comments on management of sort of refractive glaucoma in the eye with silicone oil?
Yeah, well, I mean, I typically put the tubes inferiorly, but maybe that picture.
I didn't put that tube in.
But yeah, those are difficult eyes. We actually published a series of Peter Nettler and others on tubes and silicone oil eyes. They require long-term steroids, and they're challenging. And that's an example where if you don't have to go in the eye, I think you're better off.
Actually, since like teased me a little bit, I'll tell the story of this eye. But this was a patient who presented with all these procedures done. And we didn't know any of the history, but looking carefully at the tube, you saw that little decrease in the internal lumen. And that was really the only tip that I had that this eye had silicone oil in it in the past. But something to keep an eye out for. And then now there's this, I would call it an epidemic in my institution. I'm not sure how much you're seeing, but these keratoprosthesis eyes are multiplying. And they're not easy to treat.
No. Yeah, and I don't like putting anything on the surface in these eyes. I think that, we often will pre-treat these patients with transscleral cyclophotocoagulation beforehand, and that's, I think, important. All these eyes will develop glaucoma.
Okay. You want to maybe move to the MicroPulse?
Yeah, I think, you've heard about refractory glaucoma. There are studies out there, and again, we're not going to belabor the point, but that's kind of been a sweet spot in the past. We're moving it more toward that mild or earlier patient with better visual acuity, for example, and patients that were really high risk. So we'll just finish off with, I think, some exciting work that's been done from around the world, which is actually bringing MicroPulse to transscleral diode procedures. And I think this is very intriguing. This group from Singapore has sort of discussed this paper, talking about a potentially safer procedure, maybe using it earlier in patients with milder glaucoma, and looking at an alternative mechanism of action. This is a modified probe. You can see that the settings are a little different, you see, as far as the MicroPulse duty cycle. And the idea is essentially the application is placed over the pars plana, which is actually also an area of aqueous production, but also has important qualities in terms of aqueous outflow, as we know, from a UV slow mechanism. And they found a reasonable pressure drop in this very early pilot study, and because of the very MicroPulse nature of the delivery, you can see the results were very good. So, maybe we'll just finish off with this here and just talk about the fact that, with transscleral, we've shown, I think, some long-term reports on refractory glaucoma, more moving into the eyes that have good vision as an alternative to filters. I'm not at all advocating right now as a first-line therapy, but it has a role, I think, in glaucoma, and slow burn techniques have helped, and MicroPulse may be the future, and I'll let Nate summarize the MLT.
Yeah, so from that end, we're moving a little back earlier in the disease, and MicroPulse is just versatile from a variety of ways. It's versatile in your glaucoma patient, from anyone who's just starting therapy, replacing an eye drop as an adjunct to an eye drop, or even to try to get them out of incisional surgery. In my experience, adopting this, which has mainly been in the past year, maybe year and a half, has been fantastic. It's a quiet procedure, haven't had anything that I would categorize as an adverse event, and just patients who've done generally pretty well. So again, that's an exciting option. We still have more data to collect on MicroPulse to learn exactly how much we can push the parameters, but already taking what I have today, it's a great option and something that's added very nicely and given me new options for glaucoma treatment.
Great.
All right.
Thanks, Nate.
Thank
it's been a pleasure.
Thank you very much.
Thank you, Ike.
Appreciate your time. And if anybody has any questions or any comments, yes, you can put your headsets on. You can hear it.
Now we look like
I'll let Nate answer the question.
Hi. My question is, in my experience with the G-probe and doing the cyclophotocoagulation, the main issue I've had is non-healing epithelial defects. Is that an issue you've had, and is that something you've experienced?
I have to, here's the question. The question was with the G-probe for transscleral cyclophotocoagulation, having corneal epithelial defects and non-healing. I can't say I've seen it very often. Of course, some of these eyes have really bad epithelium in the first place. And I don't know whether you're using the slow coagulation technique or not. 2 and 2, yeah. So I think probably maybe a higher risk of hitting nerves and other issues that are around the limbus area there. But I can't say I've seen it very often. I don't know about you, Nate. I can't picture it out that. I don't know, Patrick, do we see many epithelial defects after transscleral cyclophotocoagulation? Patrick did about, I don't know, a couple hundred eyes during his fellowship.
Yeah, we did at least over 200 during fellowship, and we never had any. I mean, sometimes these are really end-stage eyes, so they can have corneal edema, as you know, with the high pressures. So sometimes the cornea is not looking so good coming in, but we never add those secondary to the treatment that I experienced.
That's been our experience, but I mean, it's interesting. I mean, I could see it theoretically being an issue, but
sorry
to put you on the spot, Patrick. Sorry, I didn't.
No.
He's on a plant, by the way.
Just by the way, I had one like that in a patient with pseudoexfoliation that took a long time to heal.
Yeah.
I did, and I used the slow duration.
Yeah, I can see theoretically it happening. I mean, and we see this, after phaco surgery sometimes, a non-healing defect. But theoretically, you can imagine though, those nerves coming into the limbus, and it particularly, I mean, I don't know if do you say 3 and 9? Do you laser at 3 and 9?
Yeah.
Or do you spare 3 and 9? Yeah, I think that's probably the good idea, again, for the same reason, with those ciliary veins and the nerves coming around and venturing into the cornea. So,
yeah, my question was, for steroid-induced glaucoma and angle recession, how is MLT for that?
Okay, I have done it for angle recession. And again, no, I don't want to try to summarize, an N of 1 or 2 here, but I've been successful in some cases. I think it's like laser trabeculoplasty, SLT as well. Prognosis probably isn't as good, but again, when you're dealing with a pretty good safety profile, for me, it's usually worth a try. In steroid, I'll say the same thing, which is I think in general, trabeculoplasty has good efficacy in steroid-induced glaucoma. Janet Searle did some work for that with SLT. Yeah. It's something I would try here, and I haven't had enough numbers to comment definitively on it.
I think that's a role. I mean, it's not my first choice in steroid response glaucoma, but if I'm stuck, they've had intravitreal Kenalog and we're fighting that, I think it's a good stopgap measure.
Mm-hmm. And are you also, with your SLT, do you also treat 360 like you do with MLT?
Yeah, it's interesting. With SLT, we've actually been doing, we started off doing a lot of 180 treatments, just safety-wise and otherwise, and we do 360 in some cases, but I'm a little hesitant. MLT, we've just gone right to 360, so, but I know a lot of people do 360 SLT, so.
Yeah. Okay, thank you.
We have a question over here.
Thank you. I've done a number of the transscleral procedures with a G probe, the 2 and 2 setting in Africa, in a mission setting, where a lot of these patients have multiple inflammatory components, TB, HIV, CMV, and a few of them went on to massive inflammation, intraocular inflammation, and maybe we didn't perceive, this is before the Durezol days, but how do you treat these patients a little more aggressively, post-op, steroids? Because sometimes it can be a post-op response, and secondary IOP from the
great question. I mean, I have to be honest with you, I avoid it in uveitic eyes. Mm-hmm. So inflammatory glaucomas or inflammatory issues, I avoid it for a lot of reasons. One of them is inflammatory. The other reason is these eyes can have a very labile pressure swing, low pressure, high pressure, so I try to avoid it in general. But I do think treating in general these patients with a lot of steroid, we don't have Durezol yet in Canada, but I think that might be, aside from the steroid response issue, I think that, I don't know, I'd be interested to see what you use, but I think hitting them hard with steroids is important. Yep. But and even if you have a response like that, even oral steroids I would probably think about. But I don't have a lot of experience in uveitic eyes because I try to avoid that.
Yeah, I think it's a good point you bring up, and this is for many of our surgeries. We incite some inflammation. I'll use subconjunctival or subtenons, dexamethasone at the time that I'm doing it. If I'm in the major OR, and frankly, outpatient, I would use something more like Durezol. For me, getting ahead of that inflammation, getting to it as early as you can, has sort of been the key. And I agree, once it has a chance to sort of escape, then you're going to be playing catch up with steroids, and that's where you run into the steroid response. So, whereas I think I used to initially be afraid of giving steroids in some of these glaucoma patients, I'm much more likely to do it at the time of the surgery now, so that I can hope to spare myself more steroids down the road.
You pre-treat with a NSAID or a steroid?
Yeah, I guess
Good idea.
yeah, I do. I use a lot of, I use Durezol for 3 days prior to most of my surgeries, cataract or otherwise.
Yeah, we've had a poster and some papers on looking at our slow coagulation versus our 2-2, and I do think that the eyes are not as inflamed afterwards, but that may or may not be a factor in these uveitic eyes, though.
Yeah.
Hi, quick question. I do glaucoma and multi-specialty group. I've been doing SLT for a long time. I have partners who just bought the MicroPulse, so I'll be starting MLT. How do you, having both, I mean, is there any patient selection criteria, one versus the other? It sounds like it's pretty much a toss-up.
Yeah.
You're comparing versus SLT, you mean? Is that
Yeah.
what you're, okay.
So the question was, how do I decide between SLT and MLT? This is a great question. Again, for me, the things are, what's my tolerance for pressure spike? And with that being lower, pushes me more towards MLT. How confused is this patient by their glaucoma drops? And if they're on the more confused side, that'll push me towards MLT because I can just do it, stop a drop, and then go. And there's still like my traditional train wreck that I'm sort of banking on. This person's going to need a trab, but let's try some laser. For the most part, I've still been using SLT on those, and I'm mixing it up a little bit. Also, one neat thing is you register with Iridex or let them know you're doing it. You'll actually get patients sent to you who have learned about MicroPulse and want that as a therapy. And I've had 3 patients come to me because they learned about it through the internet, which is kind of fun and cool. And those people definitely get MLT.
I have to step out, but I know Nate's here for another 2-3 hours to answer your questions. So I apologize. I have another meeting, but thank you.
Thank you.